Well, I'm also quite happy to be here, and I think what I want to do is to push this panel a little further, to look beyond gender and think about sexuality, including gender identity. And the way I want to do this is to present some of my current research, which I think is a very good case study as to why we need to look beyond gender and include another definition. And I'm going to talk about access to healthcare for people who don't fit the heteronormative paradigm. For very practical reasons, I chose to go with the acronym LGBT, lesbian, gay, bisexual, and transgender, mostly because most of my participants in my research identified as such. But I do think it's important to recognize that these identities are not that simple. They're very often too binary, and especially in post-colonial societies carry a whole other weight of complicated identities with them. So obviously LGBT people face exactly the same health risks as the general population. There's nothing biologically special. But on top of that, emerging research over the past 10 years, mostly coming from the United States and Europe so far, has shown that LGBT people face very specific health disparities that are mostly based on stigma and social exclusion, on institutional homophobia, on societal homophobia. So for example, LGBT people have much higher rates of mental illnesses, high rates of depression, often high rates of suicide, especially among teenagers. And they all can be traced towards social exclusion based on their sexual orientation or gender identity. Now, the World Health Organization, in their Commission on Social Determinants of Health, does not recognize sexual orientation as a social determinant of health, although in the past few years there have been made very good arguments as to why this should be the case. And if social determinants of health really should reflect health equity and justice, and if that is a central tenet, then actual sexual orientation and gender identity should be recognized as such. And what my research is trying to do is make a case in point to support that claim. Now, a lot of people know that South Africa has one of the most progressive constitutions in the world, and we are one of the few countries that offers protection from discrimination based on sexual orientation and implied on gender identity. We offer it based on gender, and transgender advocates have advocated and argued around that section of gender to include gender identity. The Constitution also promises a progressive access to healthcare in the public sector to people, but the reality is that these constitutional promises have fallen very, very short. So one, we have very high levels of homophobia in society. A lot of you might have heard of the so-called correctional rapes, which is a terrible term, but a lot of violence, including sexual violence against gender non-conforming people, are taking place. And very similarly, a lot of people don't have adequate access to healthcare in the public system. The public system caters for about 80% of South Africans, is very under-resourced, and the private sector, which is a very neoliberal model private sector, at the moment hosts more than 95% of all medical specialists in the country, but only caters really to about 20% of the population. So there's a vast, vast inequity in access to healthcare. Now, we know that healthcare workers, so doctors, nurses, counselors, etc., are all members of a broader society, so healthcare is not delivered in a bubble. And South African society is actually quite conservative. In a recent poll, 61% of people said that society should not accept homosexuality. So very far from the constitutional commitments here. And we know that from other settings that many healthcare providers share the homophobic and discriminatory attitudes of wider society. In South Africa, we have emerging research that documents homophobic discrimination of non-heteronormative identity in public health facilities. So Marion Stevens did a good research with Gender Dynamics, a local transgender organization here in Cape Town, that documented transgender people's access or trying to access sexual health facilities. And then my question became, well, what barriers do LGBT South Africans face when they access public health services, if they access public health services? And very similar to the methodologies that my two previous panelists have said, I was very interested to hear about people's lived experiences. Mostly because a lot of work around sexuality recently has focused on talking about people, so I was very, very curious to really emphasize the voices coming out. So this ongoing study aims to identify two things. One, it aims to look at the intersecting barriers linked to sexual orientation, gender identity, also obviously race and class, ability, disability in accessing healthcare. But also, I wanted to identify best practices in providing LGBT inclusive healthcare. Now, for this presentation, I'm going to focus on the barriers, but I have been accused in the past of over-dramatizing, which I don't think is true. So I would like to emphasize that there has been a part of the study that looked at best practices. It's an ongoing qualitative study that I do in the Western Cape and Gauteng. I've chosen these two regions because both of them have one organization in them that actually provides services to LGBT South Africans. There's Triangle Project here in Cape Town and Out LGBT in Pretoria. And I've interviewed non-heteronormative service users, however they would identify, and I interviewed representatives from these organizations to get a bit broader and structural view. With the emerging data, I've then decided to take a framework that specifically looks at the right to health and access to health care to think through the emerging issues that come up. And I've used the UN-ICESCR's framework that was laid out in the General Comment 14 in 2000 that looked at access to healthcare as having four distinct components. One would be availability of health services, the second would be accessibility of health services, and this includes non-discrimination, physical accessibility, how far is the clinic, economic accessibility, can somebody afford the care that they would receive? Information accessibility is health information in general available to patients? And then acceptability of care, so what we often call culturally competent care, although I think the term is a little complicated when we talk about identities, because that often reduces sexual orientation to a culture. And lastly, quality of care is an essential tenet of good quality health care. So what I want to do in the next few minutes is just run through some of my findings in this framework and then discuss them in a little more detail. With regards to availability, no big surprises there. I mean, this is very well known about the South African Public Health Service, that in general, resources are very, very short. Availability of care is across the board very, very difficult. Long lines, no medicines available. What's especially concerning though, that there's a lack of LGBT-specific services. So for example, safer sex protections. No clinic in the whole country offers dental dams to lesbian women, for example. The only place to get dental dams, so one of the ways for lesbian women to use a barrier method to protect them from HIV or STIs, is to get them through a non-governmental organization. It's even worse when we think about transgender-specific healthcare, so transgender people who wish to access gender-reaffirming or reassignment services. There's 3 clinics in the country at the moment that provide these services. One is here in Cape Town for Tiskier. Their waiting list is 25 years long at the moment, because they can do up to 5 surgical procedures a year. They don't get more 3 at a time. And then there's 2 hospitals in Gauteng. The problems with these also is that there exist no South African national guidelines regarding transgender healthcare. So all of these hospitals operate completely on their own operating procedures. And while one of the clinics follows the international recognized guidelines from the World Association of Transgender Health, the other 2 don't. It appears that the other 2 don't always do that. So there's a huge gap in available services here. With regards to accessibility, I've come across many people who've told me that they have been either turned away from services or have been in many other ways felt very, very unwelcome. So either it be very flat out refusal of services. There is, and this is where intersectionality comes in, a compromised physical accessibility that plays into with non-discrimination. So one person I interviewed who also had a hearing disability and a learning disability said, well, these services pretty much leave you fending on your own. And that's when different marginalized identities intersect to make access even more complicated. A lot of the services were not up to standard and would actually not be deemed acceptable services. Lots of violations of confidentiality, healthcare workers gossiping about patient sexual orientation, gender identity, a lot of religious judgment coming from healthcare workers. So there's one quote here, the doctor's like, well, you know that God doesn't want this, right? God doesn't want you to be gay. A lot of these instances that I've heard. Also something that I came to call the curious homophobia. A lot of these very inappropriate, very invasive questions that come up from healthcare workers in a setting with a patient, where it actually has nothing to do with the health concern they came for, but it takes place in such an unequal power relationship between doctor and patient. The patients actually have no choice but answering these questions. A lot of victim blaming taking place as well, where health workers blame either the health condition or what happened to the person on their sexual orientation or gender identity. So this is one quote that illustrates this quite well. The reason why you attempted suicide is because you're having a relationship with men that's not right, the evil spirits making you do all the things you're doing. But another instance that was very, very, very instrumental to me understanding this whole concept also was a young man who identifies as gay, was openly gay, lived in a university residence, was chased by a number of guys from his residence, and had to jump out of the second floor, broke both his arms, and then went to the clinic. And obviously, people want to know what happened, and he's telling this whole story, like, but why were they chasing you? He said, well, because I'm gay. And at this point, the only thing the nurse would say, well, then you deserve this. So a lot of these stories, basically. And all of this very clearly violating ethical care, or any of the standards that we should have. Very similar to the non-availability of services, there's also hardly any knowledge about LGBT health, about specific healthcare needs for LGBT people. Our doctors and nurses are not being trained in LGBT health. The University of Cape Town, where I work, I surveyed the curriculum of the medical school, and absolutely no class teaches about non-heteronormative sex at all. So doctors are actually just not capable of providing adequate health information. So in summary of this, queer patients experience barriers related to all four components of the access framework, and very often it's the healthcare workers that act as the gatekeepers. And their reactions to non-heterosexual, non-heteronormative identities range from anywhere between the very curious, sort of well-meaning but still homophobia to open homophobia and refusal of services. And as a result, LGBT people expect discrimination at health facilities, and that has a huge impact on their accessing care. So as a consequence, a lot of people who are interviewed, they would avoid seeking care. People try not to use the public services. If they have a little money saved up, private services provide an alternative, even though they're not necessarily better very often, but there is a perception that the customer relationship that they have with their service providers would protect them from homophobia. And of very great concern was that there is no accountability in the system. So not one person who I had interviewed, and I must say that every single person I interviewed had made bad experiences and homophobic experiences. I mean, on a range, very obviously, but there has been. Everybody could recount easily one or two stories. Not one person had complained about this. Part of the problem is that the current complaint system in the South African health public system is dubious and often not very clear to patients, and it involves complaining at the facility as the first place. And the problem obviously is if you've been treated badly, if experiencing homophobia at the facility, you're not going to go to the facility manager or nursing sister in charge to complain. Either because you don't know that that's the case, or because you just expect further homophobia, and then you just walk out. So in conclusion, I think what this shows very clearly is that sexual orientation and gender identity are crucial determinants of access to health care. And that South Africa's progressive legislative framework is clearly lacking in implementation. And again, this is nothing new, we've heard this over and over again. An important thought here is the invisibility of LGBT people in the healthcare system reinforces itself. And I think that's absolutely crucial when we think about how to tackle all these health rights violations. And I mean, I could talk at length about what we should do. But I think one important step is that academic public health, health policy makers, health justice movements need to recognize sexual orientation and gender identity as a determinant of health. And we need to talk about more than gender. But also that the public health facilities need to improve care and accountability mechanisms specifically for LGBT patients. Now, one big opportunity here is the upcoming national health insurance. South Africa is reforming their public healthcare system, and part of NHI will be to put in place new accountability structures, the so-called Office of Standard Compliance. And I know the Department of Health is running a pilot in Gauteng, where they take the complaints methods away from the facility and try to centralize them. We're trying to work on a cell phone-based system where people can complain directly to a central cell phone organized base rather than going through the facilities, which we will need in order to just monitor the quantities of health rights violations going on. But yeah, that is pretty much my brief for that. All right.